That's very good. Okay, well, why don't we start the next lecture here? We'll do the lumbar spine, and now we'll talk a little bit about congenital and developmental variations. See, who did the last one? I don't know. Okay, go ahead, do it.
Okay, 54-year-old with back pain. Lumbar spine looks not too bad. There is sort of this linear, hyper-intense focus, the anterior aspect of that.
Here's the axial image through it.
Okay, so it looks like, I see it. Okay, so it looks like it's posterior to the great vessels. And could be I don't think it's a varix. It could be the lymph system, the Cisterna Chyli. Yeah.
All right. Thomas, what do you think of this case?
46-year-old with low back pain extending into the right leg. So the thecal sac is displaced towards the left side. And
here's the next cut.
Yeah, the thecal sac is asymmetric in the spinal canal.
Okay, here's the next cut. There's the next cut. So what's going on there?
There are some adhesions.
Not really adhesions. And notice the symptoms are on the opposite side. And then if we keep going down, what's happening here?
There's exiting nerve roots.
Okay, here's the normal one on the right. What's happening on the left? Next cut down shows this.
Yeah, it's sort of.
Is there a root anomaly?
Yeah, sort of like a beaded appearance.
Now I'm going to go down again. Here's the next cut. Now we're getting close to the S1. And notice here we've got asymmetry of the S1 roots. So if you go back again, here we are starting at L5. Notice here the right L5 root is getting out to exit the foramen. The left still isn't that far out. Go to the next cut down. This one is exiting. This one is still barely even entering the foramen. The foramen is kind of empty here. And if you go down, there we can see it. Now it looks like there are two things coming off that. And these two five roots go out. If we keep going down here, now we got the 4 root on one side, but now the 4 root on the right side is more immediately placed than the 4 root on the opposite side. I mean the S1 root on the opposite side, S1 root on the abnormal side, normal S1 root. So what do we call this? Oops, shit. So this is conjoined left S1 root. These are actually pretty common to the point now where I'll sometimes not even mention in the report. Typically they're good to mention because if you do surgery, it's important for the surgeon to know that this may be the case because it means the nerve roots may not be in the normal location. Generally, it's not symptomatic. It's considered a congenital anomaly, but that's a conjoined root.
Why was they pain on the right?
I don't know. I have no idea. We never know what causes back pain, right?
So it's one common origin, basically, and they branch off? Is that
well, they come down together, but they're adhesed they stay together. Let's go back again here. So actually what's happening is the 5 roots coming off on the right, the 5 and 1 root are coming off together here. But the 1 root holds it medially, so the 5 root actually buds off more inferiorly on the abnormal side than on the normal side. If we go another cut down, what we have here on the normal side, the root's really getting out in the foramen, but since this one is still connected to the S1 root, the S1 root keeps it from extending out until we get lower. And here we got both the 5 and the 1 roots together on this side. Here the 1 root is in here, the 5 roots out there. So they're kind of held together. And here, though we don't really see it right now, this is the 5 root, the 1 root's starting to bud off here. The 1 and 5 are together here. The next cut down, there's the 5, here's the 1 coming off of it. here's the one coming out of the thecal sac, and there's the 5 coming out over there.
Interesting.
And then you can follow it all the way down. So that's called a conjoined nerve root.
The surgery here, if that's the going to happen, is kind of tricky. So you don't step on the wrong root.
Yeah. Okay, Sam?
The caudate equina looks thickened. I wonder if there's a tethered cord here. And there's some, yes. Yeah, some adhesion there. Some.
A little bit of spinal here, degenerative disc disease. So here's the axial image.
Yeah, everything's kind of like, that's pretty high up there, I think, right? So you would expect to see the cord kind of more centrally located.
Now the next cut down shows this.
Right. It's,
And then
yeah.
we have that, the old snake eyes.
Yeah.
And then we have this.
I forget what this is called. Well, that just, what, Diastematomyelia or something.
This patient has
Yeah.
spina bifida, tethered cord, and Diastematomyelia. Now with the Syrinx. Diastematomyelia. Okay.
Yeah.
This one looks similar in that the conus is sort of lower down.
Yeah, so you really don't see a good conus. It comes way down here. So this is also a tethered cord,
Type Filum terminale. And so in all the reports, I like to state the level of the conus. And usually I'll start at T12L1, or I start with whatever the lowest vertebral bodies that I see. Sometimes it goes up to the higher up in the thoracic spine, and I'll start there, but there'll be a level where at T12L1 is really where the conus usually ends. So usually at that point I'll always mention the conus in the report, just to make sure that you don't miss an abnormal location of the conus. Okay. Alrighty. So you had that one, right, Chip? Okay. Thomas, what do you think of this one?
58-year-old female, sacral mass at birth with pain, left nephrectomy due to renal TB. So spina bifida at the level of the sacrum.
Well, we see lack of fusion posteriorly there, and then we have a big defect in the sacral part of the spine there. Here's the lateral projection. Here's the MR scan.
Yeah, the fat extending into the defect.
Okay. So what would you call this?
It's lipo.
There you go.
Yeah.
Spina bifida with lipomyelomeningocele and a tethered spinal cord. Yeah. Yeah. So that's a lipomyelomeningocele. And then just some literature on it. And you can also have, see, I think this is a new, oh, yeah, here we go. Okay, so this is a new case, I believe.
Looks like displaced thigh. Visual presentation, baby with fusion at lumbosacral region. He gave me the diagnosis. This is the case.
Yeah, so you can do this. So here you go. What do you think of those?
It's definitely not normal.
So what do you look for when you see something like this?
As I recall, they were separated.
I guess I would look to see if the central, spinal contents are separate. Here it looks like the bone is separate, so I would imagine that the nerves are also going to be separate.
Yeah, so what you want to do is separate them. What's important is for the critical element to be separated.
It's going to need some good grafting.
So there's no sacrum on this side, but you see a sacrum on that side. And then if you do the CT scan, what do you think this shows?
So those are urinary bladders, I guess, with fluid in them, and then you see two separate sacrums. Yeah, there. Yeah. Oh, so this actually looks like the canals are fused.
Yeah, it's getting worse as we go on.
Yeah. This doesn't help as much, I don't think. MR. This, yeah, so it looks like this is a T1, I guess. The fluid of the canal looks like it fuses most inferiorly, yeah. So I don't know that the cord is going to be higher, I guess.
Yeah. It looks pretty separate until you get down to the sacral area where you see some fusion with the nerve elements.
Oh, that's a good one. Yeah, they're probably at least touching in the inferiormost portion of it, otherwise.
So really, the only area here that's really fused is the Filum Terminale. So they went in and separated them, and they were able to successfully separate them without neurologic deficit.
I remember this case, so they were successful.
Yep. And the bones were all relatively separated. Good. Ready?
Okay, looks like, I'm not sure if I see, oh, actually, there's in one of the neural foramen up higher up, I see a hyperintense, yeah, that thing.
So what's that?
Looks like a cyst, it's not enhancing.
So that's a nerve root cyst, and they're fairly common. And they really are generally not associated with symptoms, but they're worth commenting on just so that people know what you're dealing with. So I commented. The main thing is to make sure that it's not associated with it, that you're not really dealing with a neurofibroma or some sort of a benign neurotumor there. Typically, with a nerve root cyst, foramen is normal. If you have really a benign neurologic tumor, usually there's dilation of the bony canal at that level due to the chronic presence of the tumor. And this is a common one. No enhancement. And there we can see that's another nerve root sheath cyst or nerve root cyst. Okay, Thomas, what do you think of this case?
Right, so we have a mass or some kind of a lesion in the spinal canal, sort of at the L1 level. It's extramedullary and could be extradural.
Yeah, it looks like it's outside the thecal sac to me.
Yeah, it's like displacing the thecal sac, and it's cystic. Okay.
So what would you call it?
I guess you could have an arachnoid cyst in this area.
Yeah, arachnoid cyst. Yep. Usually these are not symptomatic. And then, what do you think of this one, Sam?
Is a huge Tarlov cyst.
So it's a big cyst down in the sacrum. This is chronic. You can see that there's dilation of the canal of the sacrum, and this is a large arachnoid cyst, which is basically the same thing as really a Tarlov cyst. So this is more large and confluent, and therefore the term arachnoid cyst was preferred. Yeah, 2 decades ago, people got very concerned about arachnoid cysts when they first started seeing them all the time on MR, and people would often work them up. And the workups were always negative. They're always associated with back pain because they're only imaging people with back pain. So for a long time, people assumed that they were associated with symptoms. And I don't think there's any compelling evidence that they're associated with symptoms or really have any pathologic significance.
Okay, so it looks like there's a few sort of cystic foci at the L4-5 level.
This is T1 post.
And they're not enhancing. It looks like there's osseous remodeling, so it looks like it's probably chronic. Could be.
So these can have a lot of names. It's a kind of an arachnoid cyst. It's also called dorsal dural diverticulum. And some people think this is associated with adhesive arachnoiditis, but it doesn't have to be. Okay, Thomas.
So there's a structure kind of inferior to the sacrum.
Yeah, so here's a marker, and then you can see that structure there. Here we have on the axial images.
So it's, yeah, this is also cystic. I guess this could be a Tarlov cyst.
Well, this is really out. Yeah, you see, here's the kind of the spine and so forth. This is more in the subcutaneous tissue, but I would certainly be concerned that that's the case. This one turned out to be a pilonidal cyst, which is more of a skin lesion rather than a neural lesion. Okay.
They're difficult to treat. You can't cut deep enough to get rid of all the hair and stuff. They're filled with all kinds of tissue, but mostly it's hair, and you see this in people that are quite hairy.
Okay.
It's not unusual to have a repeat performance on these, and some people don't get an MRI on to start with, and I think that's a big mistake nowadays. I think you should have an MRI in each one of these, so that you have to cut more than you think you should.
Looks like an abnormal. Sorry.
Cut is a surgical term, by the way.
Okay.
Looks like an abnormal articulation of L5 with the sacrum on the left, and some sclerosis of the bone around it.
So what does this mean?
It can be painful because that abnormal articulation can develop degenerative changes and be painful.
Yeah, this can be a cause of pain. We'll see other examples later. Often, so I think it's important, as we talked about before, to look carefully at the L5S1 level because there are a lot of congenital anomalies there. These where you have partial sacralization on one side and not the other increase the strain typically on the disc base 2 above it. So if this is at the 5 or 1 above this, if this is at the 5-1 level, then typically you'll get abnormal strains on the 4-5 disc, and you'll get premature early degenerative disc disease. And we'll talk about a syndrome associated with this later in this lecture, which I think is one of the most commonly missed, important diagnoses in the lumbar spine that I've seen over the years in practice.
Oblique X-rays should pick it up probably easier than MRI.
Okay.
What do you think?
It can, yeah. I think they can pick it up. Sometimes the sacrum kind of overlies that area. This is an area that can be picked up well with cross-sectional imaging, but oblique X-ray is one of the reasons we always got obliques in the past, and
people who do X-rays still do is to be able to evaluate this lesion, but it is tough to see on X-rays alone because you've got the sacrum overlying this.
Okay, 47-year-old male with long history of increasing back pain. So I see some dextrocurvature of the lower lumbar spine, and
Blow it up.
yeah, I think maybe there's sacralization of the L5 on the left. Oh yeah, I see it now. Yeah, I see. It looks like there's an articulation there between the sacrum and the L5 transverse process.
So here's the MR.
Okay, it looks like there's degenerative disease at L4-5, L5.
So there's degenerative disease at both levels. Usually with this syndrome, the 5-1 is okay. But we can see degenerative disease here, a lot of end plate changes at the 4-5 level. And then...
Yeah, so it looks like there's an articulation there between the...
And then you can see here, we can also see on the axial images at the 5 level, there's an articulation on one side that's not on the other. And this is on 5/30/07.
At the right side. Doesn't that look like there's also something?
I think that's the SI joint.
I mean here?
That, yeah, like that.
Yeah, I think it's hard to tell because you've got a lot of bowel stuff overlying it.
The left also is hard to tell. Would you have thought that just based on this?
Well, this is abnormal.
Yeah, that looks abnormal.
Yeah, I think that's abnormal. And then, and so here we can see clearly abnormality on this is that articulation.
07.
On the left side. Okay, so this is 7/27/07. This wasn't described in the imaging reports at this particular time. Then the patient came back on 3/28/09, and this is what it looked like.
So worsened L4-5 degenerative disease with end plate changes now.
Disease here. Okay, and then here's some axial images here.
Okay.
And the other thing that you can note here is that the spinous processes are overlapping one another at the 4 and 5 level, which means, again, this is showing some abnormal bony alignments in this case. And on the CT scan on 6/25/09, we can see more degenerative change in that articulation on the left side. And this is what the coronal CT scan looked like.
Yeah, more degeneration.
And again, we can see this abnormal articulation on one side, not the other. All this degenerative disease at the 4-5 level, which is progressing here. And then here's what we can see on the 3Ds. So, what would you call this?
Bertolotti's syndrome.
Yeah. So this is Bertolotti's syndrome, and and it tends to be more symptomatic on one side and not the other. There is a bilateral Bertolotti syndrome, which is basically partial sacralization of the L5 vertebral body, which some people believe also may be symptomatic, but it's very clear that the unilateral disease produces a lot more strains at 4-5 and is more likely to be symptomatic. And this is something that, in my experience, is just very commonly missed, and very often it will be treated surgically not correctly because the congenital anomaly is not recognized preoperatively. So I think this is important to see. And then, so
what do they do about it?
So here's a classification system where you can there's type 1, 2, 3, and 4 with fusion and so forth. So John, if you had someone who is symptomatic with this, what would you do with them?
Ordinarily, it's a matter of fusion.
Yeah. I think that's. I'm not aware. I'm sure people have tried it. I'm not aware of it, of surgeries to try to correct the anatomic anomaly. I think the main thing is to recognize it and understand what the process is, and if you have progressive.
Well, in '84 there was no. Well, MRI was probably just a year away.
Right. Yeah.
So yeah, I think we would be dealing with myelograms and CT and fusion. I can't think of anything else.
Yeah.
Probably you need a graft from the posterior iliac spine, grafting, etc.
Yeah, and according to this paper in radiology, a type 1 and a type 3 aren't symptomatic. What you get are the types 2 and 4 are the ones which are symptomatic, which basically have a pseudoarthrosis with the sacrum, are the ones which are symptomatic. Okay, see who's next? Thomas, what do you think of this case?
45-year-old male with chronic low back pain, and looks like there's a transitional vertebral body at S1.
Okay, so this is 1, 2, 3, 4. This would be 5.
So yeah, I guess it's the sacralization of the L5 then.
And here, let me see. That's certainly a rib. Is there another one? That's probably the long rib here. So this is probably 12. No, that's probably this. Yeah, I guess there's a rib here, right? So that would be 1, 2, 3, 4. So yeah, it looks like there's probably kind of sacralization of L5. Here's what the MR scan looks like.
Right, there's associated disc disease at L4, L5.
Yeah. And then here, and then another case of Bertolotti syndrome. And then there's just an illustration of the way to classify these. But most people just describe the findings and yeah, it's really the asymmetry in this disease. The symmetric problems typically don't cause a lot of symptoms. It's the asymmetry that you have to look for. So why don't we stop here and we'll pick up this level tomorrow. Okay?
Thank you.
Yeah. Have a good evening, everyone. I don't think all of these need surgery.
Yeah.
So it's a matter of symptoms and the patient's wishes.
Right.
And I'm not sure what to do with them because I don't think I've operated on one.
Okay. Thank you.
And I sure would remember if I have.
Yeah. Right. Okay.